Welcome, everybody. It is April 5th, 11 a.m., another Friday, and we have another amazing guest today. Uh, our guest happens to be a Florida native, I just learned. Audrey Blewer is a PhD. She's got her MPH. She's an epidemiologist and a resuscitation scientist in at Duke University School of Medicine. And, we always have these brilliant people who are not front-facing clinically, but really help us clinicians out by doing the work that they do. Many of you know Tanner Smita. He's similar in that regard. He's done some great work. And so I reached out to Audrey after seeing her publication and reading it and thought it would be very interesting for us. So Audrey, thank you for joining us. If you want to give any further introduction, and then you can share your screen and take it away. Thank you so much for joining us.
Yeah, so just as a little bit of background on myself, I have had the opportunity of being in the resuscitation field for about 10 to 15 years now, but just, more formally as far as my credentials, yeah, I'm a PhD epidemiologist and have my master's in public health and really enjoy approaching these questions from what I'd like to call just more of a public health perspective. And these are my disclosures as it relates to this current presentation. But more specifically, the way in which I've structured this presentation is, kind of going back to the science of what we're doing, why we're doing what we're doing, and then talking through a little bit of our current project that is being conducted in North Carolina and the manuscript that Peter identified and asked me to share today. But as I walk through this, I'm sure that this may be possibly redundant to some of the knowledge that you all have, but hopefully the presentation of it is stimulating and motivates some conversation. But as we know, out of hospital cardiac arrest is a huge public health problem with over 350,000 individuals experiencing out of hospital cardiac arrest annually and less than 10% surviving to hospital discharge. For me, this just really encourages and motivates me to think about how can we increase survival more generally. And specific to the research that I do, I think, many of us are aware of the chain of survival, but more broadly, we know that, out of hospital cardiac arrest survival depends on several existing therapies and links in the chain of survival, including, rapidly calling 911, prompt delivery of cardiopulmonary resuscitation, and early defibrillation, all of which have motivated a lot of my line of research. And just going back to a bit of the science behind this, what I'm highlighting here is an article published in New England Journal of Medicine in 2015. And this publication was out of Sweden and used a registry in Sweden. And as you can see here, bystander CPR is associated with more than a doubling in survival. So this right here with the y-axis, we see the survival rate in the population, and the green line shows CPR before EMS arrival, contrasted to the individuals that did not receive CPR before EMS arrival. And then in addition to that, we know that there is just huge precedence for thinking about early defibrillation. And what I'm highlighting here is, one of the earlier publications around early defibrillation in the PAD trial that was published in New England Journal of Medicine. And again, we're really encouraged to see that, the survivor number of those in this particular cohort that received CPR and defibrillation as compared to those that just received CPR. And again, just reinforcing the importance of early defibrillation as well. So I think, more generally, this has motivated many of us to think about, what can we do to increase some of these bystander focused interventions more generally. And I had this publication with a team in Singapore as part of my appointment at Duke University. I also have a joint appointment at Duke NUS in Singapore, which is also a medical school in Singapore. And Marcus Ong has this robust infrastructure out in Singapore, really motivated around pre-hospital emergency response and out-of-hospital cardiac arrest. And we had this publication looking at the impact of bystander-focused public health interventions on CPR and survival. So in their particular population, over about approximately a 10-year period of time, they rolled out EMS interventions, dispatch-assisted CPR, CPR training, and then what I'm highlighting here in the final line was also a crowdsourcing mobile application. And what we saw was, again, this is an observational cohort study, but we saw that the rollout of dispatch-assisted CPR and CPR training, in addition to the crowd sourcing app that's similar to our Pulse Point, all was associated with an increase of bystander CPR and survival as well. And again, I'm highlighting the limitation of this being, an observational cohort study, but I think it still speaks to the importance of, these community interventions focused on the bystander, and also arguably what they had done as well as EMS interventions as well. So this brings us to our publication, where we were looking at how this is really well and good, and this is important. I think all of us really acknowledge the importance of rolling out these types of interventions, but how do we generate and facilitate support across communities and EMS agencies for these interventions? And how do we promote and sustain the implementation of these interventions? These are all real true knowledge gaps, and important for us to understand because, as many of us probably know, it is tough to maintain enthusiasm for these particular interventions. So to examine this, we leveraged the infrastructure of the race cars trial. And I'll tell you a little bit about the trial in the next few slides. So as I highlighted through the previous publication that we had in Lancet Public Health, we recognize that there's evidence supporting that the community interventions work and that they're important, but there are very few studies out there demonstrating effectiveness of these particular interventions through a randomized control trial. And that's where this race cars trial is. That's kind of the knowledge gap that this race cars trial is addressing. So we are in year 4 of a cluster randomized trial in North Carolina, which is looking at the impact of community and EMS care improvement and feedback interventions. And this is being conducted in 62 counties within North Carolina, with the goal of enrolling about 20,000 patients. And again, we're in year 4 of 7. And the intervention, again, is specific to community and EMS interventions, and the control is usual care, continuing standard quality improvement efforts. So the primary endpoint is hospital survival with good neurologic outcome, and the second outcomes are rates of bystander CPR and defibrillation prior to EMS arrival. And so the PI of this trial is Dr. Chris Granger. He's in the DCRI and also at Duke, and must acknowledge the many individuals that are working on this trial and are necessary to make this happen. And I'm just one of many. So as you can see here, this is the participating counties as of spring 2024. The red are the intervention arm, the dark gray are the control arm, and the light gray are those that are not participating. And what's important to identify through this is that it's a good mixture of both urban and rural populations that are participating in this particular trial. And the 4 interventions include rapid cardiac arrest recognition protocols that trigger immediate priority EMS first responder dispatch by 911 telecommunicators. The second is systematic bystander resuscitation instruction by 911 telecommunicators. And the third is comprehensive community training of lay people in CPR and AED use. And the fourth, optimized first responder performance, including earlier use of AEDs. So again, just getting at a lot of what I mentioned earlier with the science. And so for the purposes of the paper that I'm presenting, we were looking at factors impacting support for in both the community and EMS agencies. And for the purposes of this discussion, we're using the definition of support of the act of agreeing to or accepting an idea. So this is particularly based off of prior knowledge, knowing that obtaining support from key informants is critical to the success of new interventions. And this is largely drawing from the implementation science research. To inform our interview guide, we use the consolidated framework for implementation research. So this framework actually consolidates a lot of the known theories and models and developed quite a few constructs that cross several domains of importance. And we can think of it more generally as kind of the community and then the interpersonal and inner settings. And I'm highlighting the sampling framework, and this is important for our knowledge, just more on the clinical side, that when thinking about the individuals that we spoke with, we first considered the county's just overall cardiac arrest performance, and this was based off of prior years of data and counties entering into the CARES registry. But it's important to note that we considered cardiac arrest volume, their CPR performance and survival as well. And then we also spoke with the implementation coordinator to gauge perceived engagement of these counties. And then the counties were then divided into high and low, and then we randomly selected counties within this breakdown. And then as you can see here, we interviewed EMS, telecommunicators, fire first responders, and hospital representatives within each county. And then more broadly, we were really interested in looking at adoption of interventions, and then just more generally how we can increase reach and adoption specifically to CPR and early defibrillation. And then we also considered other subpopulations. So more specifically, we were really interested in looking at differences with regards to race, ethnicity, socioeconomic status, and gender. And this is a subject for another paper that we're working on currently. So it's important to note that this is being conducted as part of the larger race cars trial. And what we are doing is, as part of the implementation science team, we're working with the trial to share back information about what's working and what isn't working. So that can kind of inform your thinking about how we're looking at this question of buy-in. So we were rapidly analyzing the data and feeding it back to the race cars team. And as you can see here, we were able to speak with let's say an arguably pretty balanced representation of participants in both high and low performing counties across all of these different affiliations. And then as you can see here, we got a decent balance of urban and rural as well as senior leadership, and then people that were in other roles within the agency as well. So I'm going to walk through this particular slide in a little bit more depth, and then happy to discuss it a bit more once this presentation concludes. But these are the summary of the findings around initiating and maintaining support with EMS agencies. So in one of the low performing counties, we saw in terms of initiating support at agencies that there's initial resistance to changes or new interventions, but one strategy was identified: holding meetings with stakeholders either as a group or one-on-one to build foundational relationships. And then as far as similarities in this column, we also saw people expressing the need to be creative with presenting the rationale for new changes or a new intervention, introducing the intervention or changes by someone who is very familiar with or has experience with the intervention. In terms of obtaining support from emergency response teams, it was emphasized to maintain simplicity when explaining the intervention, ensuring the team members clearly understand their role in assisting in implementing the intervention before launching the intervention, training and education, as well as creating an outlet for frequent communication about the intervention, and develop easily accessible, detailed explanations of the intervention. As far as maintaining support, as far as similarities, we saw individuals expressing providing regular updates to the emergency response agencies, including quantitative and anecdotal data that shows patient outcome improvement. And then lastly, in terms of obtaining support from agency staff and obtaining support from senior leadership, we saw differences from high and low performing counties. And in terms of high performing counties, they expressed some barriers, including needing approval from multiple people, especially if the emergency responders working in a hospital-based system. The inability to collaborate with health departments and financial challenges that was expressed by multiple people. In addition to that, in low performing counties, we saw agency leaders need to set a positive and collaborative attitude in order to generate support from teams. So as far as some of the quotes, what I'm highlighting here is just, I'm going to highlight one quote, and this largely motivated a bit of the direction that we're taking as far as our current analyses and looking at a bit more at fire engagement in this capacity. But an interesting quote we received is, "I've got guys that have spent their entire careers in the fire service that have never run medical calls, so they've been a little reluctant. And I'll be honest, it can be a little scary because now you're not putting water on fire, you're putting hands on people, and their lives depend on that." So it's just getting over that change and working through the education piece to make sure everybody understands what the goal is and why you're doing what you're trying to do. And this was a fire chief from a low performing county. And that really spoke to a lot of us and resonated with the race cars leadership team as well. And then another quote that we received is, "You have to be open to feedback. You have to establish a feedback mechanism," because we got people that were like, "Yeah, it makes sense that you want it to go, but that's also where we put our drinks in our gloves. It's like, man, we made this change, but it doesn't seem like things are changing, or we're getting poor compliance with people following the directive. That's probably a reason." So again, this, I think, highlights the importance of the feedback loop. And I think just me as a researcher working in this space, I've seen this and multiple projects that I'm working on, just the necessity of that feedback loop when it comes to out of hospital cardiac arrest, and also helping people understand the importance of the change and where they fit in the bigger projects. So in conclusion, we saw that effective implementation of community-based out-of-hospital cardiac arrest interventions may be facilitated by training, good communication, effective data sharing, and regular meetings with teams and stakeholders. And we're now focusing a bit more on fire buy-in. But more as far as practical next steps, I'm highlighting a bit of what we're doing in terms of those 4 buckets that I just outlined. This is work that's currently being done. So as far as training, we have a manual of operations that's shared with EMS to share with partners, and also hard copies taken to site visits, regional meetings, and state meetings. And it's written in simple terms with ongoing updates of latest science and best practices. We're encouraging EMS and fire to work together on team-based CPR, and EMS to train fire on team-based CPR. Also integrating fire in the community training partners for teaching hands-only CPR. And then more generally, a letter is sent out to all partners. As far as communication, we're working to close the feedback loop on outcome, which I think is something that I see as very important, across the board. The Duke team travels to all the sites to help facilitate engagement. There's a slide deck developed and tailored for sites to use for training and approach and engage fire. More generally, a quarterly newsletter is sent out to EMS to share with partners, and that includes things like, success stories, best practices. And EMS is the liaison to fire to share trial updates, and everybody's invited to state meetings, which is held in 2 locations in the state. As far as data sharing, this is data that's being taken from CARES and is sent out quarterly to EMS and 911, and it has specifics on things such as CPR, AED application, defibrillation, and response times. And more generally, in terms of regular meetings, a lot of what we, continue to stress, and I think this is also, taken more generally from some past initiatives, including Heart Rescue, is survivor celebrations, importance of highlighting the bystanders, meeting survivors, staff recognition. So this is something that we've been thinking about a bit more, and how to recognize 911 and all of those that are integral in the chain of survival. EMS is being mentored in how to engage local and state government resources, including county commissioners and legislators. And there's also monthly calls that occur that includes 911, EMS, and then fire as well. And when meetings are created or initiated by the Duke team, they try to incorporate a survivor story at the beginning. And if a survivor is unable to attend, EMS often does a case study of their arrest. And so this is highlighting some things that have been recently been conducted through some of these counties. So Hoke County is a rural volunteer fire county, and they just started a deputy medic program. So as you can see here, this was published March 19th, 2024, and that was picked up by Spectrum Local News, which is really exciting. And then this is an image of a recent survivor celebration in Davidson County. And as we can see here, the middle is the survivor with some of the staff that took care of him, and the representation of all staff, including in this particular image, including 911, EMS, fire, law, hospital, and other individuals that were instrumental in the chain of survival. And then this is a Hearts and Heroes celebration that was recently held in Caribous County. And this is actually, I think, the funny picture that was taken from the particular celebration. But I think what's really encouraging to me is just the number of people that came together, the diversity of the backgrounds that was included in this particular image, and just it's really exciting to see people coming together and just celebrating survivors' success stories, and just highlighting the importance of working to improve this chain of survival more generally for out-of-hospital cardiac arrest. So these are key members of the race cars team that were really instrumental and a lot of what was represented just here. And again, Chris Granger's the PI of this, but there's many investigators involved. And then more generally, the implementation science team is listed here as well. And yeah, happy to take any questions.
Wonderful. That's an amazing presentation. I have so many questions and thoughts. And I know, I'm sure other people have a few questions as well, but I'll start. First of all, I can't even imagine being the quoted fire chief of a low performing county. So how did all that go down? How do you say, okay, you're the low performing guy and you're the high performing guy? Can you kind of explain that aspect of it, and how has that impacted those folks, number one? And then number two is, what I really think is happening here is that this is you guys are really creating like a leadership playbook, right? Of basically, how do you make a low performing county high performing? And I would be fascinated to understand, what are all the items that are making these people low versus high performing?
Yeah, no, that's a great question. So I may have skipped over this rather quickly, but so what we did was we looked at the CARES CARES data in these North Carolina counties, and then looked at the county's cardiac arrest volume, percent of bystander CPR performed, patient survival to hospital discharge, CPC after cardiac arrest, and then perceived engagement. And then the study team basically, added a quantifiable number to this, which created a number that we could then divide the counties into high and then low performing. So the performance is based again off of cardiac arrest volume and then basically the bystander CPR, survival, CPC after cardiac arrest, and then again this more subjective element of engagement. And then within that, they were just randomly selected. And a bit of this, I think, when we were thinking about it was how from here it's surrogate measures for how the bystanders are responding and what's needed in terms of engaging the bystanders for these interventions, how fire first responders are responding as well. And then the other main element of this bigger project is 911 telecommunicators. So that's a little bit of what went into kind of looking at these two counties or breaking up these counties and then speaking to the individuals more generally. But when you look at it in a bigger scheme of things, there's a lot of heterogeneity.
Oh, I can imagine. Yeah. All right. Excellent. So I know we only have a few minutes. I see Dr. Lee has his microphone unmuted and Dr. Pepe. Either of you gentlemen want to make a comment?
Hey, Peter, I have to go, so I apologize, Dr. Lee. But there's about 20 things I can tell you. By the way, great presentation, great work. And just please, give me a call sometime because I got a bunch of suggestions for you because we've been doing this. So beyond the obvious things like we did getting into the school systems, like we did in Seattle back in the day, a couple of things is to make sure that what you do with the training is really to the point, reiterative, redundancy. Some of the things that Peter and I have done, for example, have been to apologize for that background noise. Some things that we've done is make sure that we are make it real simple, like talking about choking. You just go pop the cork. Know where the AED. Two things you need about AEDs: know where they are, go get it, turn on. So I can go over that with you sometime. But one of the other things I was going to say is that's not thought about often is that I always start off when I go into a community with teaching this county commissioners or whomever it is, city commissioners, city council members, offering those classes, and they often save lives. Then you move on to saying, let's train all city employees. What people don't realize that the city and county governments are often the largest employers, and you can get them, later on in the thing, especially if you can do it in a short form that we just said. And then they can encourage larger companies in that area. Whether you're say if you're in Cary, you can go to American Airlines or whatever it might be. So, and then the way you really also say it's sustainable because you might train everybody up front and your firefighters and police are already trained. So you then go on and then say it's sustainable because if they have a 10 or 15% attrition every year, they could retrain the new people coming in as part of their orientation, et cetera, with some of these, easy kits that we have. But the last thing I wanted to say, because I got to unfortunately move along, is if you do further research, and this is sort of a little bit on the side, a whole different issue, but what people have always reported when you're talking about your bystander CPR studies, it's always reported as a binary equation, bystander CPR or not. And what we learned over the years is that it actually makes a difference about how soon they started the CPR. So if there was a way to somehow help track the time between when someone's collapsed and when someone started the CPR, it'd be very, very interesting. You'll see that because peripheral vascular relaxation takes over in an anoxic condition, the CPR is not as effective if you start it later. So just another way to encourage people, everyone to know it and do it right away, not wait for someone else to come do it for you. Then there's about 40 other things, but I'll just leave it at that. I hope that was useful for you anyway, just some things right off the top of my head. Okay.
Yeah, no, that's great. And yeah, I 100% agree. I hope that I'm not 100% certain. I think that we're working on the time data, but as you guys know, that's so tricky to calculate.
Yep.
And that's me, not necessarily, talking so much about this particular trial, but just, wearing my hat as an epidemiologist. It's still really, really messy depending on what data sets you're looking at. But yeah, really great suggestions.
Okay, thanks.
Great
Yeah.
insight. And Paul, I'll connect you and Audrey. Let's bring in Dr. Lee. Dr. Lee.
Peter, can you hear me?
Yes.
Well, that's by mistake. I'm having some trouble with the controls on my computer. So I didn't really mean to have my mute off, but I can't get it turned back off. Anyway, but I do want to compliment the presenter on this, on the work. Looks like a lot of effort and I think very key information, but I didn't really have any question. Sorry, I can't get my mute off.
No, it's okay. It's okay. Well, if I don't see any other hands, but clearly I think all of us who are on the call who manage these differing departments recognize that this old saying that you see one EMS agency, you've seen one EMS agency, and I'm fascinated by all the factors that go into that happening, whether it be the fact that the tax base is not high enough and the folks don't get paid well, and the fact that they don't get paid well, they don't have the job satisfaction, or there's no good EMS leadership or medical direction involvement. And there's so many factors that can play a role. And many of us on this call have been part of organizations that have been able to turn the corner from low performing into high performing. And we can look back now and see that it's because of certain individuals that have really made our departments, fly high. And then there's certain individuals that can drag down a department until they retire, right? And so I'm fascinated by what you'll find with the overall race cars trial, because it's probably a lot of the things that are kind of in the grooves, if you will, that are things that can make a county become a high performing county over time. So we're definitely await your publication. Loved all the insight you brought for us, but we're going to pop over to Dr. Pepe's webinar. But Audrey, I'm going to give you the last word. You have a lot of people, hundreds of people are going to hear your webinar here and on YouTube. So give us some final comments. And again, thanks for joining us.
Yeah, and I really appreciate this, really appreciate the opportunity. And I think for me, more generally, I think that it's really encouraging to be working with group of people and more broadly a resuscitation community that's doing what they can to increase bystander CPR, early access to defibrillation, and more generally pre-hospital emergency response to out-of-hospital cardiac arrest. So happy to collaborate, speak with others offline, and yeah, looking forward to next steps.
Excellent. Excellent. All right. Well, thank you so much. I'm going to put the link in the chat here to move over to Dr. Pepe's webinar. Let me just do that. But Audrey, thank you so much. That was amazing. And we'll definitely stay in contact. And once your race cars trial comes out, we'd love to have you back, you and others on your team.
Thank you.
Okay, you're welcome. And everyone, you can see the link in the chat. Hop over to Dr. Pepe's webinar. I'll see you on the other side. Thanks, everyone. Good to see you. Have a great weekend.